To close or not to close? The clinical indications for iatrogenic atrial septal defect closure following transcatheter mitral valve repair. A case report. Here, we present a 72-year-old male with a past medical history of coronary artery disease status post percutaneous coronary intervention, coronary artery bypass graft surgery, heart failure with reduced ejection fraction, and mitral regurgitation status post mitral clip, who presented to the hospital with worsening shortness of breath. He was found to be in cardiorenal syndrome with worsening renal indices despite diuresis. Patient was ultimately transferred to the cardiac ICU for right ventricular dysfunction and close hemodynamic monitoring in the setting of volume overload with intravascular depletion and cardiogenic shock. His hospital course was further complicated as he developed acute hypoxic respiratory failure, requiring emergent intubation. Etiology for his hypoxia was further explained on his stress esophageal echocardiogram, which revealed an atrial septal defect with bidirectional flow in addition to a patent foramen ovale with right to left shunt. The decision was made due to his persistent hypoxia to undergo PFO and ASD closure, which resulted in immediate significant improvement of his oxygenation. Laboratory results were significant for an increased brain natriuretic peptide, acute kidney injury, and hypoxemia in the arterial blood gas. In this image, we can appreciate the atrial septal defect with bidirectional flow in addition to a patent foramen ovale with a right to left shunt. Here, we can appreciate the saturation of oxygen before the ASD PFO closure of 77%. In the following image, we can see the saturation of oxygen improving up to 90% after the ASD and PFO closure. This image was taken after the procedure, and it shows the complexity of the case as the patient has many devices in place. The most repaired valve in the United States remains the mitral valve, with increasing patients undergoing these procedures yearly. Since access to the left atrium is gained via transseptal route, this creates a persistent iatrogenic atrial septal defect in approximately 24% to 50% of patients. In several studies, this iatrogenic defect can lead to overt heart failure, specifically due to the associated right heart volume overload and even death. In contrast, several studies have shown an association between iatrogenic atrial septal defect and improved hemodynamics due to the decreasing wedge pressures and ultimately greater quality of life and exercise capacity. Due to the contrasting data, studies have compared closure versus conservative therapy. Ultimately, closure was not superior to conservative therapy. Unlike those trials, our patient had known elevated right-sided pressures pre-procedure and a significant bidirectional shunt. Although further studies are needed, it appears closure will be beneficial in large ASDs, large left-to-right shunt, right-to-left shunt with hypoxemia, severe right ventricular dysfunction, and patients who suffer from pulmonary hypertension. As it stands, there are not guidelines in when to repair these iatrogenic defects, and the clinical decision should be tailored to the specific patient's symptoms. The decision of whether and when to close the iatrogenic atrial septal defect is a challenging one. In our case, the decision to intervene immediately was based on the patient hypoxia, multiple comorbidities, including poor pulmonary function, right-to-left shunting, and pre-existing right heart dysfunction. Immediate closure was therefore considered superior to a watchful waiting approach. Immediate closure of iatrogenic atrial septal defects should be considered when the hemodynamic and clinical picture suggests an inability to tolerate shunting at the atrial level. Thank you for your time and attention.